movement, which we should not underestimate. I too was reassured to hear the Noble Lord say that palliative care must be commissioned, but share again the concern of the Noble Lord, Lord Hunt, around when we come to Amendment 16, the word appropriate is used, and it's not quite the same thing. And so I wonder whether the Noble Earl, the Minister, could reassure the House about the Government's expectations regarding the nature of palliative care services that the ICB Board will commission, and how will they ensure that that is delivered in a way that creates consistency and is care that is rightly deserved by people in our communities, but also reflects the skill and hard work of our palliative care practitioners.
My Lords, I too congratulate the Minister and his officials, all the ministers, for listening to the House and the strong representations he received at committee on this issue. I welcome the Government's amendment and also add my name to pay tribute to the work of the Noble Baroness Lady Finlay, and also the many noble members of this House and the campaign of organisations such as Marie Curie in getting us to this point. I think it's really wonderful that the symbol of Marie Curie is a daffodil, and we are here today on St David's Day being led by the Noble Baroness Lady Finlay of Llandaff. I feel that's very appropriate. I disagree with Lord Howarth of Newport. I feel this is a historic moment. It's a huge step forward. It's the first time in the history of the NHS that there will be an explicit requirement to commission palliative care. What's brought me to this issue is I should declare my interests as Chair of the Scottish Government's National Advisory Committee for Neurological Conditions and a trustee of the Neurological Alliance of Scotland. And it has been the issue that for many people with long-term progressive conditions, they have not been able to access palliative care at an early enough point, which will not only ensure better outcomes for them, but it's also a better use of NHS resources. So I hope that the result of the Government's amendment will ensure that these people get better care and get the palliative care they need. And I hope that the ICBs will recognise the difference that they could make. So I welcome the Noble Earl, Lord Howe's opening remarks about taking the criteria set out in Amendment 17, or in the name of the Noble Baroness Lady Finlay, that I was happy to add my name to, which does provide a helpful set of guidance for ICBs to follow based on standards. And I echo the Noble Lord Howarth's question about ensuring that we have the right reporting requirements. And I'm grateful to hear that, that the Government will be developing statutory guidance to ensure that we put the necessary tools in place. But it does concern me that in my meetings, as far as I've been able to ascertain with NHS England on how they report on services rather than medicines or specific procedures, that they have been, when reporting on NICE guidelines for services, NHS England seem to rely on, and I quote, noise in the system to ensure whether they know something is or isn't happening. And I share some of our colleagues' worry about the word appropriateness. And I hope that if we develop statutory guidance based on the criteria set out in Amendment 17, then the risks that the word appropriateness might risk continuing to see a postcode lottery will be somehow allayed. Finally, my Lords, given the ICBs are at different stages of their development, can the Minister and the Department give careful consideration to the ongoing and direct communication to ICBs regarding this duty? Will they consider writing to all ICB chairs to ensure that they are fully aware of the duty and their responsibilities? The Government has made a very important step forward today in giving people who are facing end of lives the reassurance they and their families need. The focus must be must now be on making sure that this amendment is used to its fullest by the ICBs, and so that everyone who needs palliative care can benefit.
I rise to speak extremely briefly and to add my very strong support to Amendment 17, promoting the provision of specialist multi-professional palliative care services, and also to comment and generally welcome the Government's Amendment 16 on the same topic. I, like all other noble lords, pay tribute to my noble friend Baroness Finlay for her tireless work to improve palliative care services. And it is, of course, most welcome that the Government has tabled an amendment in this field. However, the Government's amendment leaves it to the ICB to decide what standard and extent of palliative care services are appropriate, that's their word, to meet what they deem to be the reasonable, and again that's the Government word, requirement of their populations. And yet the whole issue is what do these terms mean? Does the Minister accept that the amendment does not ensure that adequate specialist palliative care services will become available across the country? And that is, of course, what we all desperately want to see. So I'm hoping that the Minister, in his response, can define the terms appropriate. What does the Government mean by appropriate palliative care services? And what do they mean by reasonable palliative care services, or reasonable level of palliative care services? As I said at committee, it is unbelievable to me that the NHS provides services according to need throughout our lives until we're dying, when of course our health needs are at their greatest. At that stage, precious hospices have to raise their own money, as others have said in the past, to finance their doctors and nurses to care for the dying. Inevitably, hospital beds lie empty. 50% of beds in a hospice I visited recently were indeed empty because they simply hadn't got the staff to deal with patients in those beds. Can the Minister confirm that the Government will provide statutory guidance to supplement Amendment 16 to clarify what the Government actually means by these terms, appropriate and reasonable? As things stand, I strongly support the amendment of Baroness Finlay. As we die, we should all have high-quality palliative care services. We can then expect that when assisted dying is legalised, a reasonably small percentage of dying people will suffer unbearably despite benefiting from top-quality services. Because, of course, there are situations when the best possible palliative care services have done everything they possibly can, and yet certain patients will suffer unbearably. For those patients, we need a change in the law to ensure that those patients have control over the suffering that they can reasonably tolerate. So I look forward to the Minister's response and, as I say, hope that he will clarify the definitions of these terms used in the amendment.
Lords, it seems to me clear that this amendment is put into the subsection 1 of the clause 3. And what it says is referring to all that follows it. An integrated care board must arrange for the provision of the following to such extent as it considers necessary to meet the reasonable requirements of the people for whom it has responsibility. Now, it seems to me that you have to look at the reasonable requirements in relation to all that's in that list. And of course, the first thing is hospital accommodation. And the idea that there might be some areas with no hospital access at all is absolutely ridiculous. And so this, I think, is a qualification of the later amendment, which is fitted in at GA. And it has immediately in front of it another amendment, another provision, which refers to what it considers appropriate as part of the health service. Well, that seems to me to suggest that it's absolutely essential that the needs requirements, and it must be the reasonable requirements, that's to say, of people who are needing palliative care. Don't provide palliative care for the whole community, but you're required to provide palliative care for the sort of proportion of people that are to be expected to require it, namely those who are getting near the gates of death. I think that's the reasonable interpretation of this clause, and I do believe that it goes quite a long distance in the way that Baroness Finlay and others for some years have asked for, because I don't think it's feasible to say that nobody in an area will require palliative care, because these will be the people that live forever, of which there are only very few. So it looks to me as though this is well constructed to ensure that palliative care must be provided where people die in the area of the authority, the Integrated Care Board. I, of course, entirely welcome Lady Finlay's Amendment 17, but I think the crucial amendment is provided by the government in a way that will be very difficult for any care board to try to escape, because I think it's very clear. I also would like to join with the tribute that has been made to Lord reference to the widow who was such, of whom he is the widower, who was such a tremendous source of value in this House, including, as many of you will remember, the time when she was able to get this House to repeal or to set aside the order that was made about capital provision for poorer people.
My Lords, I'll be very brief. Having spoken on this at committee, I simply wish to thank my noble friend the Minister for bringing forward Amendment 16 to include palliative care services within the list of things required by ICBs to commission. We all agree that the end of life is one of those times when care is needed most. And I too would like to congratulate the noble Baroness Finlay for all her work on this and for all those who spoke in support at committee stage. This is an example of where the government has truly listened and responded to concerns voiced on all sides of the House. They have made the most of this bill's unique opportunity to ensure that nobody with a terminal illness misses out on the care and support that they need, both now and in the future.
My Lords, may I congratulate the noble lady Baroness Finlay, without whom this amendment would not have been laid by the government, although I do pay tribute to the government for listening to her. But as she said, it could be game-changing, and I say could be, because unless the amount of resources made available for these services, for training enough of the health professionals needed to carry out these services and to make them available everywhere, then it won't be game-changing. So I'd like a reassurance from the Noble Lord the Minister that is it the Noble L the Minister, that adequate resources will be made available so that, as appropriate, ICBs can carry out the duty that's going to be put upon them. I was horrified to hear about the hospice with half-empty beds that the noble lady Baroness Meacher mentioned. So I would hope that additional resources will be provided for hospices. I do remember clearly during committee somebody said you wouldn't expect to have a coffee morning or a cake bake to treat a broken leg. Well, you shouldn't have to do the same sort of thing for services at the end of life. And so I do hope the noble Lord the Minister will bear that possibility in mind, that additional resources should go there. We've heard that services are patchy across the country, and I would suggest that the worst patchiness is in services for people who are dying at home. And I know it's not easy to provide 24-hour services and advice to a family that are doing their best to try to care for somebody who's dying at home. But it must be done, and I'm afraid I do know friends who've had a very bad experience about that, and the person at the end of life had a bad experience, and the family have never forgotten it. It is possible, as the noble Lady Baroness Finlay has often told us, for everybody to have a good death if the right services are provided to them, and that means a good experience for the family too, who want to know simply that they have done the best and that that has been enough.
My Lords, from these benches I'm very glad to continue our support to see palliative care as part of a comprehensive health service, literally from the cradle to the grave, no matter who you are, whatever your age and where you live. And I join other noble lords in paying tribute and giving appreciation to the noble Lady Baroness Finlay for her persistence and professionalism over many years. And I do hope that the real tribute to the efforts of the noble Lady Baroness Finlay will be in the delivery of real change to the quality of people's lives and the quality of people's deaths. And I would also add my appreciation to all those charities and hospices who have also been a force for good in seeking this change. I welcome the government amendment in this area, and share in so doing simply say to Noble Earl the Minister that I do hope that it is heard the numbers of questions that have been put today, because clearly there is concern around the words appropriate and reasonable, and I would add a few questions to the ones that have already been put to try and explore that further. I'm sure that the Noble Earl the Minister understands that your Lordship's House is simply trying to ensure that I'm sure what is intended will actually be delivered. But the additional questions that I would wish to add is to seek the Minister, the Noble Earl the Minister's confirmation about how the government's expectations will be conveyed to ICBs and how they will understand what is expected of them in terms of the nature of palliative care services that they would be required to commission. It would also be helpful if the Noble Earl the Minister could commit to providing a definition of specialist palliative care services, referring I would suggest to the amendment that has been tabled by the Noble Lady Baroness Finlay, so that we can see a consistent standard and provision of services across the country. And my final question would be that to request that the Noble Earl the Minister confirm that it is the government's intention to communicate with all ICBs that they should fulfil what are the true requirements of this amendment, and to also tell your Lordship's House how this will be monitored. The Right Reverend Prelate, the Bishop of London, and other noble lords have made it quite clear that we would like the matter to be settled by this amendment, but it isn't entirely. I do hope that the government will not lose the opportunity to really make the transformation in order that we can all expect and have the opportunity to have a good death, as we would also want to have a good life.
My Lords, I'm very grateful to all noble lords who've spoken in this important short debate, but most particularly, if I may I express my thanks to the noble Baroness Lady Finlay for the illumination that she shed on the reality of well-functioning palliative care services from her personal perspective. Without repeating what I said earlier, the government does recognise and understand the strength of feeling on the issue of variation among access to palliative care services. And I do understand the line of questioning posed by a number of noble lords on the strength of the imperative that's implicit in the government amendment. The noble Baroness Lady Brinton, the noble Lord Hunt, Noble Baroness Lady Meacher and Noble Baroness Lady Walmsley all had questions on that theme. Now, I think the first thing for me to say is that I do agree with Lady Finlay. This is a game-changing amendment because it would specifically require, and the word is require, integrated care boards to commission such services or facilities for palliative care, including specialist palliative care, as they consider appropriate for meeting the reasonable requirements of the people for whom they have responsibility. Now, questions have been asked about the word appropriate. I don't think there is any other word that could be fitted in to this context. You have to talk about what is appropriate when the extent of need and the requirements of the local population inevitably vary according to the locality. So it is for the board to judge what is appropriate to meet that need in the local area and appropriate to the nature of the palliative care provision that may exist in an area, where, for example, whether it's a hospital, a hospice, social care, hospices at home, and all of the panoply of palliative care provision that noble lords will be familiar with. And my noble and learned friend, Lord Mackay of Clashfern, made a very helpful intervention on that issue, and I thank him for that. So we would therefore expect palliative care to be commissioned by every ICB. When it comes to resources, it will be for them to allocate resources to meet the needs of their population that they identify. But I would just add to that as regards funding more broadly, the House will know that there is a multifaceted funding pattern in the palliative care field. Palliative and end-of-life care services are delivered by services and staff across the NHS, social care, the voluntary and community sector, and independent hospices. And we recognise the vital role that hospices and other voluntary organisations play in the delivery and funding of palliative and end-of-life care, and we continue to engage proactively with our stakeholders on an ongoing basis in order to understand the issues that they face. Now, those are not bald words. As part of the NHS COVID response, over £400 million has been made available to hospices since the start of the pandemic to secure and increase additional NHS capacity and enable hospital discharge. The Noble Baroness Lady Brinton asked me about statutory guidance. There is already a range of guidance available to commissioners about the provision of palliative and end-of-life care, including detailed evidence-based guidance from the National Institute for Health and Care Excellence, and we will continue to keep the guidance under review. NHS England and Improvement has also made funding available to 7 palliative and end-of-life care strategic clinical networks, which will support commissioners in the delivery of outstanding clinical care with sustainability of commissioning as guiding principles. The noble Lord Howarth and my noble friend Lady Fraser touched on the issue of transparency and reporting, and perhaps I could just point to our later amendments which require ICBs to set out how they are intending to commission services and to report on that in their annual report. And that will of course, include palliative care. I can also give an assurance that about the guidance that we're not only looking at it currently, we will continue to keep the range of guidance that is available to commissioners under review. In answer to the noble Baroness Lady Merrin about what the government's expectations are in this area, I can only say that our expectations as of now are set out in this amendment, and in the guidance that we will be issuing, and the assurance that we will engage with in our dealings with NHS England. So, my Lords, I hope that I have been able to reassure the House that the government is absolutely committed to ensuring that people receive high quality palliative care if and when they need it. And I would invite the House to support Amendment 16, which I beg to move.
The question is that the amendment be agreed to. As many as that opinion will say content, contrary not content, the contents have it. Amendment 17, Baroness Finlay, not moved. In Schedule 3, Amendment 18, Lord Lowe of Dalston.
My Lords, I rise to speak to this amendment on behalf of my noble friend Lord Lowe, who's unable to move it because of a failure of his technology. I commend the noble Lord's sustained advocacy for the issues raised by the amendment, and I declare my interest as founder and chair of the charity Books Beyond Words, which has published a word-free book called Looking After My Eyes, jointly with the charity Seeability, which briefed my noble friend and myself on this amendment. The amendment seeks to improve primary ophthalmic services for people with learning disabilities, including pupils in special schools. There's no system of national monitoring of the number of people with learning disabilities that have visual impairment. Some research has estimated that people with learning disabilities are 10 times more likely to have serious eye problems than the general population, and 6 in 10 people with learning disabilities need glasses, but they may not recognise that they have sight problems. They may not be able to communicate this effectively. They certainly need reasonable adjustments to access ophthalmic services. The prevalence of visual impairment increases with the severity of someone's learning disability. And we know that some conditions associated with a learning disability, such as Down syndrome, are associated with specific causes of visual impairment, such as cataracts. My noble friend commented at committee stage that the charity Seeability had identified that 4 in 10 children in special schools have never had a sight test, and that half of adults with learning disabilities have not had a sight test within the recommended period. In short, those most in need of high-quality eye care are arguably those least likely to get it. We need targeted improvements in primary eye care for all people with learning disability. I am therefore very pleased to support my noble friend's amendment, and in my noble friend's absence, I beg to move.
Amendment proposed, page 159, line 16. At the end, insert the words as printed on the marshalled list.
I just want to say I think that that's perfectly correct and reasonable.
My Lords, I'm very grateful to the noble Baroness Lady Hollins for bringing this debate on behalf of the noble Lord Lowe this evening. My Lords, I'm the first to agree that the provision of primary ophthalmic services for people with learning disabilities is important. This is indeed why the majority of people with more severe learning disabilities are already likely to be eligible for free NHS sight tests. However, we do recognise that more needs to be done in this area to improve access to services. For that very reason, the NHS long-term plan made a commitment to ensure that children and young people with a learning disability, autism or both, in special residential schools have access to eyesight checks. NHS England commenced a proof of concept programme in 2021-22 to a further pilot access to sight tests in special schools. Any future national commissioning model will be informed by an evaluation of this pilot, and I would ask the noble Baroness to accept that we need to wait for its learning before pushing too far ahead. NHS England will continue to engage providers in the development of any future programme of work beyond the existing proof of concept, and I'm sure that the Minister for Primary Care, as well as my noble friend Lord Kamal, would be happy to meet with the noble Baroness and the noble Lord to discuss the programme further. Finally, I would remind the House that the imperative to improve access to these services is part and parcel of the duties placed on ICBs and NHS England to reduce inequalities in accessing health services and inequalities in health outcomes. The work NHS England has undertaken in this space is a demonstration of how seriously they take these duties. So, my Lords, I hope on the basis of the answer I've been able to give and the Government's commitment to update Noble Lords on the future development of this service, that the Noble Baroness will be content to withdraw this amendment on behalf of her noble friend.
I thank the noble lady, the Minister, for a very sympathetic response to the amendment, and I appreciate the importance of waiting for proof of concept for, as spelt out. One of the remaining issues, of course, is that training on how to adapt services for people with learning disabilities is also important, but I'm hoping that the proposed mandatory training in learning disability and autism will help to address that further. On this basis, I'm content to withdraw the amendment.
Is it your Lordship's pleasure that the amendment be withdrawn? It is by leave withdrawn. In clause 20, amendment 19, Lord Farmer.
My Lords, in reintroducing this amendment number 19, I would like to pick up on comments made by the noble Lord Kamal at committee stage. He said he agreed with the spirit of my amendment and had been reassured since becoming a health minister by the number of people in meetings who have said they want to move towards a focus on prevention. Although, of course, the duty to improve continuously the quality of services and obtain appropriate advice includes those in connection with prevention, this in no way guarantees it will be raised up from the current low bar relative to treatment. I don't think it is misusing the important concept of levelling up to apply it in this context. The thrust of my amendment is to level up the emphasis on addressing the precursors of illness with delivering care whilst it runs its course, and with what comes after, whether that is its sequelae, rehabilitation, or palliative care. After all, the NHS is a national health service. Keeping people healthy and preventing ill health should be the first duty of integrated care boards, thereby fulfilling the purpose of the NHS. The chronic waiting lists and the ever-increasing costs, which seem never to end, both flow from a culture which is reactive rather than proactive. As my amendment states, a duty to prevent could mean, in many contexts, community health provision. A reverse beaching for healthcare would help to nip any developing conditions in the bud, and when health needs have family implications, enable them to be treated alongside and integrated with early family help. Prohibitively, long journeys to hospitals where ICBs might choose to integrate health and health-related services to reduce inequalities with respect to access will work against this prevention imperative, hence the need to give it primacy. A couple of examples will be helpful here. I will touch on how preventing, for example, childhood obesity and mental ill health will, in no small part, require improving family relationships, which is best done in the community. The Leeds Child Healthy Weight Plan, established and led by Public Health, but multi-agency in approach, focuses on prevention, as it can be more difficult to engage families and see improvement once problems arise. Families on the plan took healthier steps in fruit, vegetable and sugary drink consumption and physical activity, but they also reported a reduction in screen time and an increase parenting confidence. Leeds has seen child obesity rates among reception-age children declining significantly as a result, particularly among the most disadvantaged children, over a period when similar cities and England have seen no change in this key area. Finally, in a recent major study of over 43,000 children in children and young people's mental health services, over half cited family difficulties. These were the biggest presenting problem. So again, community-based family support is vital for preventing mental ill health. In concluding, and as you can see I'm not long, I want to stand back. Tragic events in Eastern Europe indicate the need to spend more money on defence. Where will it come from if we do not cut our cloth differently? Prevention of ill health has to be a part of that. My Lords, I beg to move.
Amendment proposed. Page 16, line 12. At the end, insert the words as printed on the marshalled list.
My Lords, I beg, I rise to speak to Amendment 33 and to 37 to 54. And I thank the noble Lords who've added their names to these amendments. It's a very simple point here. The purpose of these amendments is to make sure that primary care is as highly influential in the new system and not the poor relation of NHS trusts and NHS foundation trusts. And that, my Lords, is vital for the whole success of this entire bill in moving forward, that primary care is able to play its proper part in the future. So it's very good indeed that the bill does include having a representative of primary care on the board of ICBs, of the integrated care boards. That's very good. But let me turn to the problem, and it's exemplified by the first one of these amendments, which is number 33. Number 33 refers to a passage in the bill which says that before the start of each financial year, an integrated care board and its partner NHS trusts and NHS foundation trusts must prepare a plan setting out how they propose to exercise their functions in the next 5 years. There is no mention of primary care in that. And that is where the amendment comes in, adding in the words "and primary care." And it is worth just noting that this is an entire reversal of what is in a sense the current situation, where primary care has a big role within planning and the acute and NHS trusts more generally have a much lesser one. So this is a very big change. So the question that I have first of all for the noble Lord the Minister is, it would be helpful if you would explain why NHS trusts are being treated different, NHS trusts and foundation trusts are being treated differently from primary care, and going alongside that, why and how will you make sure that primary care will be able to function as it should do in being equally influential with the other sectors? The reasons for this I've already outlined in very broad terms, but let me just pick out 3 or 4 points. Firstly, so that their contribution can be made. And primary care is not just about what is happening in the out-of-hospital sector. They also have a significant role in what should be happening in the hospital sector. And of course, to pick up on the noble Lord Farmer's point, a major role in prevention as well. Secondly, this is also about morale, and primary care has very poor morale at the moment, and I think that anything that seems to downgrade their role is important. Thirdly, it's about messaging and about the priority that is being given to the different parts of the system. And fourthly, there's another point here, which is that over the last, I guess it must be 25 years, a number of GPs in particular have become really quite adept at planning and thinking about the future and commissioning and so on. And there's a great wealth of experience there. And that's not just experience of planning for primary care, it is also experience of planning for health services and indeed prevention more generally. And then, of course, as I said at the beginning, this is about the direction of travel. Now, I'm pleased to say that I have had some good discussions with the noble Lord the Minister and indeed with officials, and I'm looking forward to hearing what the noble Lord the Minister will be able to say in response to this. My request, or a request to myself and the noble Lords who've added their names to the amendment, couldn't really be simpler. Why is it intended to treat NHS trusts and NHS foundation trusts differently and giving them apparently a more central role? And how will the Noble Lord the Minister give the same level of influence to primary care as it does to these other bodies?
My Lords, I have one amendment in this group, but I would like to support the thrust of the debate so far, and I should declare that I'm a Fellow of the Royal College of General Practitioners, having previously worked as a GP. Lord Farmer, the Noble Lord Farmer, in opening, really stressed the importance of trying to prevent ill health later on and to bring a population up to be less unwell than the current population is. And in terms of managing people in the community, we do have to have a very strong primary care workforce. At the moment, there has been a great move to try to move people out of hospital back into the community, but primary care at the moment is creaking under the load, and the social care services aren't there for much of the social care support that these people need. So primary care has got to be factored in as a major contributor the more and more we expect people to be looked after at home, nearer home and in the community. And in rural areas that can be particularly difficult, where the GPs are expected to take on much broader responsibilities than they would be. They may even be managing some of the accident services as well in the area, working with the ambulance services. The amendment I've got down is about rehabilitation, and part of the reason for it being in this group, and I think it's appropriate that it is that recovery from any episode will have a period of rehabilitation, and that must be factored in. People will need physiotherapy expertise, they will need occupational therapy, they'll need speech and language therapists coming in, they may need podiatry, they may need to be have the technology supplied to them to manage their own condition at home and learn about managing that. And the patient and the family themselves may need education in terms of how to manage their own rehabilitation and their recovery. After a major accident, when the person is clearly through that critical phase as to whether they're going to survive or not, they then have a very, very long haul of rehabilitation, which may take years and may need ongoing support if they're ever to realise the true potential that they can realise within the limitations. And there have been some astounding examples of catastrophic injury where people later on have gone on to contribute enormously into their own families and in life, but they have needed really intensive rehabilitation services over a long time. So my amendment is there to make sure that this doesn't get forgotten in the way that services are commissioned and are planned for, and that rehabilitation is viewed as an integral part of the follow-on after the acute phase and out into the community as people get home and transition from hospital into community to look towards resume a life. It may well be very different to the life they had before, but that will enable them to fulfil their potential.